It is January the 8th, 2021. We are continuing on with cardiac A&P. Lovely to see everybody's faces that's available. Right now we have 13 out of 20 students that are on live, okay? The ones that are usually on live and paying attention live are the ones that are able to rat off information. When I asked about the heart, some of you were able to go through it just like that. And that's the ones who've been on live and taking notes. It's not going to just sink into your head, okay? So we're going to pick up where we left off. Don't forget to be in your Egan's book. The syllabus tells you the chapters to look at for cardiac A&P, chapter 10, I think 13 and 16. There's a few of them. And so we're going to be doing some things in the book as well. Now, homework has been put into your module for this weekend. The homework will consist of defining the key terms on page 206, which is chapter 10, and then 268, which is chapter, I think, 16. No, 268 is chapter 13. 268, I believe, let's see here. Yep. Chapter 10 and chapter 13's key terms, they're blue, okay? They look like this at the bottom of your Egan's book, the big book. This is the Egan's book, okay? These are the key terms down here. Those are the key terms for chapter 10, which is page 206, and then chapter 13, page 268, also has some key terms. The first one has about 71 terms. On page 206, there are 71 terms for you to define. And then 13 only has like 20 something, I think. But you got all weekend to do it. You got tonight, Saturday night, and all day Sunday. It's not due till Sunday at midnight, right? That is your homework. I already put it in so you can be, have that on your mind to get that done. Any of these terms are fair game on the exam. You might have some define this term, define that term on the exam. So make sure you're studying these terminologies. Also, these late assignments that keep trickling in, I'm going to stop accepting late assignments. Whenever the due date is set in the calendar, that's what time your assignment is due. If you don't get that assignment in by that time, I'm going to stop accepting it. Now, I've done it for the first couple, the whole first module, the first one of this second module, but now it's time to start getting in gear. All right, we got too much going on to be, oh, I turned that in yesterday and I'm going to turn it in tomorrow. This is class, and you have a deadline, okay? If it's a lot or you have some situations with you like a day before, hey, something's going on, I won't be able to do my homework tonight, whatever, we can talk about it, as long as it's few and far in between, okay? But if it's something you got to tell me every single day, I'm not going to take that, okay? We have to stay on top of the game. Now, if I do accept it late, I will accept it with points off, okay? I've already told you that you got 100 for all your homework. I've already given you 100 for all the homeworks for each section. But if you continue to turn them in late, I may accept it for your attendance, but I will not give you full credit. And then we'll start knocking your grade down, okay? And every point helps in RT 210, okay? All right, this is all about accountability. It's totally the student's accountability. This is when you're becoming a professional. If you're not already a professional, you're coming into respiratory profession, okay? It's all about your accountability, your time management, and how you're able to handle situations at hand, right? Patients' lives are on the line. Their lives are on the line. All right, so let's share my screen. Go back to the lesson plan. I want to pick up right here at pulse. Before the pulse is when we talked about the pathway of circulation, right? We've already done the pathway of circulation, but then the PowerPoint, I think, skips the pulse part. I want to go back to the pulse part to make sure we have that information. The pulse. Pulse reflects the contraction of the left ventricle, also known as systole. I hope you guys have written those AKAs down so we can, if you haven't, we're going to go ahead and write them down today. All right. I want you to put depolarization, AKA systole, AKA squeeze, AKA top number of the blood pressure. I'm going to write it on the board. Systole, AKA depolarization, AKA squeeze, and AKA top number of the blood pressure. All right. Make sure you can see me. My black, so it's a little bit better to see. Depolarization, AKA squeeze, AKA systole, AKA, what I say, top number of blood pressure. Depolarization, AKA squeeze, AKA systole, AKA blood pressure, top number of the blood pressure. And we can also say pulse. The pulse. That's what you feel when you feel for somebody's pulse. Beat, beat, bump, thump, thump, thump. You're feeling the depolarization, the squeeze, the systole, and the pulse of the ventricles. You're feeling the depolarization of the ventricle, the squeeze of the ventricle, the systole of the ventricle. The pulse is what this is of the ventricle. You're feeling your ventricles, right? This is the ventricles, right? You have your right ventricle, your left ventricle. They squeeze at the same time, guys. Don't think that the left side and the right side is all I hear the thump, thump. It's not that. The ventricle squeeze at the same time. The atrial squeeze, then the ventricle squeezes at the same time, okay? Now, what you're feeling is because the blood, when the left ventricle squeezes, it's pushing blood to your arteries, okay? And that's what you're feeling. But when they squeeze, it squeezes at the same time. The right side is pushing blood to the lungs, and the left side is squeezing blood to the body, okay? Squeeze at the same time. Make sure you have this, because I may talk about, we're going to start talking about the EKG. And on the EKG tracing, this is the QRS. The QRS of your EKG is the pulse, the depolarization, the squeeze, the systole of the ventricles. That's what makes this shape on your EKG. Every time you see this, it's a beat, okay? And we're going to talk about this more in a minute. Now, this one here is the P wave. The little bitty wave before that is the P wave. That is when my atria depolarize or squeeze or contract, okay? And then the QRS is when the ventricle does it. So it's atrial ventricle, atrial ventricle, atrial ventricle, okay? And the T wave over here, this one here, is when the ventricle relaxes or repolarizes, okay? Now, we're going to, like I said, we're going to do this in depth in a minute. I just want you to see what I'm talking about. So I want you to have these AKAs down, because now we got to do the other one. We're talking about the pulse, and that's when you can palpate your heartbeat. When you can feel it here, that's your carotid pulse. Here is your radial pulse, right? Here is your brachial pulse. Here is your femoral pulse. And then you have one on the top of your foot called Dorsalis Pedis. There's a pulse on the top of your feet. A lot of times when the physician goes to the room, they feel the patient's legs and they feel to see if they have pulses on their feet to make sure that they're circulating, make sure their circulation is making it to the feet. If not, they're going to start dying and become infected and got to get chopped. Okay? So that's what this is. Now let's do repolarization. Just to get our AKAs down. Make sure you put these AKAs on the same sheet you put the AKAs for CO2. The CO2, AKA ventilation, AKA respiratory, AKA acid. Those that I did, have you an AKA sheet, because that's what I like to do. Sometimes I like to compare these terms that you're going to see that mean the same thing, and you can go to your sheet and say, oh, okay, all of them are together so you can study them. Now, after that pulse or after that contraction or depolarization, the heart has to relax, okay? So relax, AKA repolarization. Repolarization, AKA relax. AKA the bottom number of blood pressure. That repolarization is this here, the T wave. The T wave is repolarization. That's the relaxation of the ventricle, okay? Of the ventricle. Relax of ventricle, AKA repolarization, AKA the bottom number of the blood pressure. Now, when I ask you a question, the questions may have these terms. So for instance, if I said, what is the pressure in the heart at repolarization? And I forgot one, AKA diastole. So relaxation of the ventricle, AKA repolarization, AKA the bottom number of the blood pressure, and AKA diastole. So if I ask you a question, what is the pressure in the heart at repolarization?
80.
80. 80 what?
Millimeters of mercury.
Good. 80 millimeters of mercury. See, you might see, it might say, what is the diastolic number, right? Diastolic number is 80, and the systolic is 120, right? When it contracts or depolarizes, that pressure should be about 120 millimeters of mercury. And when it relaxes, it should be about 80 millimeters of mercury. But they might not say systolic or diastolic. They may say depolarization or repolarization or relaxing or squeeze. You never know. That's why you need to know them all. Okay? And where it is. They'll say, what part of the EKG represents repolarization? You're going to say the T wave. Okay? The T wave. All right, so we're going to get into that, but I want you to make sure you understand those terms. So let's go back to pulse.
And which one represents depolarization?
The QRS. All right. Now, so the pulse. The pulse reflects the contraction of the left ventricle. That's what you can feel. But during depolarization, they both are contracting at the same time. But what you can feel is the actual pulse. So that's the left side pushing blood to the systemic circulation, right? The right side is pulmonary circulation. The left side is systemic circulation, all right? You're supposed to take your pulse with your fingers, not your thumb. So when you're taking somebody's pulse, make sure you're taking it like this. So radial pulse. Radial artery is the one across my thumb, right under my thumb, okay? That's my radial artery. We usually take our pulse radial, okay? You'll see the nurse or the doctor or RT taking, or the MA, taking your pulse with their fingers. You should use your two fingers and not your thumb, okay? Why wouldn't you use your thumb? What would be the...
Because it's a pulse in your thumb.
What? What'd you say?
Well, isn't it a pulse in your thumb?
Oh, no. No. Hold on. I said when you take a pulse, we always want to take the pulse with our two fingers under the patient's thumb, because this is where the radial artery is, okay? The radial artery does this. It goes up and it loops in the hand and comes down, and this on this side is now the ulnar artery. Radial, ulnar, okay? But when we palpate, which means feel, somebody's pulse, we want to palpate it right here under their thumb, okay? That's the radial pulse, okay? Now, they say when you take somebody's pulse, don't use your thumb, use your two fingers. And I want you to critically think, what would be the rationale of not using your thumb to take somebody else's pulse?
You wouldn't be able to feel it as...
Yeah, you'll feel it. You'll feel something. Anybody else with a rationale? No.
Is it because you'd feel your pulse instead of theirs?
There you go. You might be feeling your pulse. When you put your thumb on there, your radial pulse is right under your thumb as well. So you may be, once you start pushing pressure, you might be feeling your own pulse. Okay, so that may give you a false reading because theirs is 80 and yours is 120. You've been feeling yours the whole time. Okay, therefore we may treat them for being tachycardic and they're not really tachycardic. Okay, so you use your two fingers to take the pulse. Now let's go over these places of arteries. My artery's not on my little picture, but don't worry, we got it in here. And it's in the book too as well. All right, so let's keep on going. All right, share my screen. All right, so these are the sites, guys, for taking somebody's pulse. The radial pulse, the carotid or femoral pulse, the temporal pulse, the ulnar pulse, the brachial pulse, and Dorsalis Pedis pulse. Okay, let me find exactly where that's at in the book right quick, because I'm pretty sure there's something we can, I don't know which chapter right off the hand, but I'm gonna look up right quick pulse sites. $7.89. Let me show you on me. It's in one of the chapters, but I don't have time to flip through all the chapters to find it. All right, here we go. Watch me. The radial pulse is here. This is your radial pulse. Up your thumb, right under the thumb. That's your radial, okay? Your ulnar, U-L-N-E-R, something like A-R, ulnar is over here. This is your ulnar pulse, okay? What happens is the artery goes up and it loops in the hand and comes back down, okay? Now, question, can I feel my pulse in a vein? Yes or no? Think about it.
No.
Okay, you got one no. Anybody else, anything different?
I think no too.
Okay. So for the ones that said no, why can't I feel my pulse in my vein?
Our blood back, or bring the blood from the heart, so it wouldn't really have like a pulse to it because it's coming from the heart.
Well, okay, you're right. Veins are part of pulmonary circulation, right? All your veins are part of the pulmonary circulation. So the systemic side is what you feel. When it say we say left ventricle through the aortic valve to the aorta and to the body, right? So when that blood swoosh to the body, you're only feeling it in arteries because arteries take blood away from the heart. Okay, so all of your arteries is where you can feel the thump, 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 right? Every time that ventricle squeezes, right? So that's why you can't feel them in your veins. You can only feel it in your artery because that's where the blood is leaving the heart, okay? So radial, ulnar, then brachial. Brachial artery is right in here, okay? Then carotid. The carotid pulse is here or over here. Right across from the trachea is your carotid pulse. Okay? Now, before I stand up, I want everybody to feel your radial pulse. Turn your camera on. Let me see you touch your radial pulse. Good. All right. You with us, Heather, Kiara, Maria? All right. Show me your, good. Show me your ulnar pulse. Put your finger on your ulnar. See if you can feel it. Sometimes you have to press a little down a little bit. This will be ulnar. All right, everybody show me your brachial pulse. You feel it? Talisha, you alive, ain't it? Good. Now, some people make the mistake, guys, of touching for your brachial over here. It's not going to be distal to the body. It's going to be more proximal. So it's closer to the trunk of the body. It's on your arm on this side, the inside, okay? You should be able to feel your brachial pulse. This is where we take the blood pressure. When we listen to somebody and we take their manual blood pressure, we're listening to the pressure in the brachial artery. Okay, that's what we're testing. Okay, we take the blood pressure over the brachial artery. All right, now, you don't have to show me this one, but I'm going to show you. This is the femoral artery, right in here, in the groin. So if you're laying down, feel your groin. It's right where your leg stops and your groin starts, and that crack down in here. You should be able to feel your femoral artery, the femoral pulse. Now that one will be kind of deep unless you're really thin. The femoral pulse is what we check for in emergency. If you come in with a trauma, gunshots, we checking your femoral. We're not checking up here because in a situation of shock, the body will shunt all the blood to the midsection. So you might not have no pulse on your hands or your feet, but your inside, your midsection is thumping because the heart, the body wants to live. Even if you don't want to live and try to kill yourself, the body will stop the blood from everything except for your head and your trunk. So we always feel for the femoral pulse in an emergency situation. All right. Last one is Dorsalis Pedis, which is at the top of my foot. Running across the top of your foot, there's an artery there. You feel down in there, you should be able to feel your pulses in your feet. This is very important that we check this, or the doctors or nurses will check this every shift on a patient to make sure they still have pulses to their feet. Okay, circulation. If you can't feel it, sometimes we use what's called a Doppler. And it's a little microphone that we put the microphone there and listen for. Shoot, whoo, 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 whoo. If we can't feel it and you can hear it, it's there. Okay, a lot of times you can't so light. The blood pressure may be so low that you can't feel it. Okay, go ahead, Talisha.
So when I was doing brachial, in my right arm, it's very light, but in my left arm, it's strong. Why is that?
I don't know. I guess it's because your left side of your body is more of your systemic, because it's coming right off the left side of your heart, right? It goes to the left side, but when it goes to the arteries, it goes both of them at the same time. But there is a slight difference in blood pressure from your left arm and your right arm. So that's probably what you're feeling, a difference in pressure, okay? Usually when we take somebody's blood pressure, we use the left arm, not the right arm. But they usually should be really close, but it is a little bit higher than the right, okay? And also, what was I going to say? I forgot. But anyway, the left side is usually higher than the right side. That's probably what you're feeling, a difference in pressure, okay? All right.
Also, in your femoral arteries, like down here, in a heavier person, are we supposed to feel like under the, I don't know.
Yeah, you got to dig down in there and get to it. You're going to get down close to the bone, right?
Okay.
Femoral pulse will be down here. Oh, this is Mr. Johnson. His femoral pulse will be right in here.
Okay.
That big femoral, that's an artery right there. It's hard to see that red one. See the red one? That's a femoral artery, and the blue one is a femoral vein. Okay? This artery is what you can feel right here and right here. See that one right there? And that one right there. And it's down there by the bone. So you just have to go in there and really push down in there to feel it. Make sure you do, because if you don't feel it and nobody's really pushing, they'll call it. They say, okay, well, we call it. We ain't got no pulse. We've done what we can do. He dead. Right? And then that's when you call it, and then next thing you know, he come up out the bag on you, and scare you to death. Okay, it happens. They think somebody dead and they not. So make sure you're digging deep. I hate for that to ruin your little career because it scared you to death. All right. So let's go back. What time is it? 43. Okay. Now, blood pressure. This is one thing you're going to be taking, blood pressure, when you're on campus for lab. All you need to really know about the blood pressure is how we do it and what are the devices needed for blood pressure. There's two things that are necessary to take a blood pressure. That's going to be a test question. The two things is a sphygmomanometer, and a stethoscope. The two most important things, or two mandatory things you need to have for blood pressure, is a sphygmomanometer and a stethoscope. When we come back from break, I will show you the sphygmomanometer and the stethoscope, okay? Good, Kiara. All right, so what is a sphygmomanometer? It's a column of mercury. Now, it used to be in a glass tube. You see how old this is? It's not in glass anymore. It's just a plastic, it's usually a meter in a plastic container, right? It used to be mercury. Now it's a manometer, a needle that moves, okay? Now, but the same process as reflected through the stethoscope, it measures the blood pressure sounds, okay? So what happens is when we squeeze the blood pressure cuff, the sphygmomanometer, we squeeze the cuff on the arm till it gets real tight and it occludes the brachial sound, okay? So what you do is you have your stethoscope on the patient's brachial artery and you're listening to it and thumping, thump, thump, thump. And then you start to squeeze the cuff. You continue to squeeze it till you can't hear it anymore. You have occluded it, okay? And then you will open it up just slightly and let the manometer start moving. As you do that, the sounds will come back. The first time you hear a thump, that is your systolic pressure. And so for instance, it would do this. The needle will be, you have pumped it up and it'll start doing this. And then you'll hear thump, 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 thump. And when you don't hear it anymore, that's the bottom number, the diastolic number. So the first sound you hear after you started letting it come back, right, is the systolic, the first thump you hear. And the last thump that you hear is the diastolic number. And that is a manual blood pressure. The manual blood pressure is the most accurate blood pressure you can take. Yes, we have those drop-off machines that are real nice and convenient, that'll do it automatic, do it digital, the wrist ones that do it digital. But the best way, as you get that question, the most accurate way to take a blood pressure is manually, okay? Everybody must know how to do this because you can't depend on things to work. And if in a situation of emergency and the monitor is not working, you need to be able to take that patient's blood pressure because that is vital to life. If their blood pressure has bottomed out and they become hypotensive, they die on you, okay? All right, so let's take a break. I'm gonna pause the recording. Okay, guys, break is over. We're gonna continue on where we left off. Now I want to show you before we go on about the blood pressure. This is a sphygmomanometer here. This is the sphygmomanometer. It even says it, sphygmomanometer. It used to be a glass tube with mercury in it. You know, mercury is the same, the red mercury that you see in a thermometer, a glass thermometer when the mercury rises. And the mercury rises for the pressure, temperature because of the pressure, okay? You're gonna learn that pressure and temperature and volume all go some type of hand in hand. Either they're directly related or they're indirectly related, okay? You're gonna learn it when we get to gas laws and physics. that pressure and temperature and volume and all that, very important. So what makes you think that glass thermometer, what makes the mercury go up? It's not because it just gets hotter. It's because when a surface gets hotter, the pressure increases, and the pressure inside of the glass tube increases and pushes the manometer up. Okay, and that's how you read your temperature. Okay, the same thing is with let's just talk about right quick the pressure and temperature when it comes to those sprayers that you spray your keyboard with. Yeah, anybody ever seen those little handheld? You put a little stick out and you spray it. It's a spray can and it's just air and it sprays your keyboard real good. Well, somebody tell me what happens when you spray it for a while. What happens to the can?
It gets cold.
It's cold because temperature and pressure are related. Okay, so as the pressure decreases, the temperature also decreases. Okay, because the pressure inside that can is high, and when you open it up, you're releasing the pressure out of it. It's dropping. So as the pressure drops, so does the temperature. That's physics. You might not have thought about it, but that's physics. Same things happening in our bodies. Okay, so with that being said, this is a sphygmomanometer, right? And it's connected to a cuff. This is the blood pressure cuff. You will put this over the patient's brachial artery, okay? And when you do that, you have your stethoscope, of course. Now, this is a learning stethoscope that has 2 sets of earpieces. So when you're doing somebody's lab, I can listen to see if I'm hearing the same thing you hear, all right? So you will put on your stethoscope. Now, keep in mind that a stethoscope has 2 settings. This is the diaphragm, and this is the bell, okay? This is the hollow tube that leads to the binaural earpieces, okay? Now, this one happens to have 2 settings where I can turn it, okay? Whichever side you have it turned and primed to is the one you can hear really good. So right now, I don't hear that because I got it set to the bell side. But when I turn it over, now that's really, really loud, okay? Just barely touching it, okay? Your stethoscope that you have also turns. The one that we gave you, it turns. So make sure you're on the right one because I don't hear nothing, probably because you don't have it turned right. So I would listen to the patient's brachial pulse. Okay, so there it is right there. So then I will put the cuff on there and then stick this in here and then start pumping. Now, you have to turn this to the right to close it before you start pumping. Remember, righty-tighty, lefty-loosey. Turning to the left opens or loosens it. Turning to the right tightens it or closes it. Righty-tighty, lefty-loosey. That's what everything made in the world. To turn it on, you turn it to the left. To turn it off, you turn it to the right. When you're screwing in a screwdriver, to the left, backs it out. To the right, screws it in. Okay? All right. So I will tighten it and then start to squeeze it. See how the meter goes up? Go to about 180. And then I start letting it go. That's about how fast you want it to go. Not faster, not slower. Now notice you didn't see any ticks because it's not hooked up to nobody's arm. When it's hooked to somebody's arm, you will hear it. Okay, as that manometer is going back, the first sound you hear, you say where your needle was. So for instance, if the needle was right here, when you hear the first one, let me show you. If the needle is right here when you hear the first sound, then what is that?
130.
130. So if it's moving and it start, you hear it, boom, right there, and it boom, 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 and you keep on hearing it till let me show you here. Let's see, 130 and right there. What if it stops right there? That's the last place you hear it. About 97, something like that. That will be your bottom note. So it's simple, guys. You just squeeze it till you don't hear the brachial artery anymore, and then you open it up. As it starts to go, you wait and listen. Now, you can see it tick, but you can't go by the tick. Okay, you have to go by what you hear because you may see it move and you don't hear it. You don't count it unless you hear it. Okay.
I've always had trouble with blood pressure, like hearing it.
Yeah, it might be because you just didn't have your stethoscope in the right place or in your ears the right way. It takes a little practice. All right. So that's how you take a manual blood pressure. Okay. We will be, you will be needing to get in your lab book, the pages that's in the lab book. You need to be looking at over the weekend as well, getting that out the way so that you can see the process and see what the, remind you what the artery is that we're working with, how the patient should be sitting, and stuff like that. You need to make sure you read that so you're ready for that on lab day. Okay. It's in your lab book, and that page and all that is in the syllabus. All right.
Will you say one more time when we hear the dystolic versus the
when you squeeze it,
beat?
Yeah, when you squeeze it all the way, you open it up. It's going to start moving. The first beat you hear is the systolic, and it will keep beating, and then it will end up stop beating. The last beat you hear is the diastolic. Got it? All right, here it is right here. The procedure. Put the stethoscope over the brachial pulse point. Inflate the cuff until blood flow stops. You don't hear the pulse. Slowly deflate the cuff. The first sound is the systolic blood pressure, and then the change in the muffling sound is the diastolic. So they say change in sound, but it's usually the last one you hear, okay? The last sound you hear is the diastole. So systole is the first sound, and diastole will be the last sound, okay? Blood pressure is always recorded in the patient's chart, of course. So that's the procedure. If you didn't get what I said or you need to see it, that's the procedure right here on taking a blood pressure. All right. Now we have to get into cardiac cycling. We learned the blood flow through the heart, but what about the electrical pathway? There's also an electrical pathway to the heart, and that's on page 355 in your Egan's book. So if you open up your Egan's book to 355, it's going to start talking about the electrical pathway. We're going to get into how to read the EKGs, what the waves mean, okay? All of that kind of stuff's coming up now. If you look at page 355, there's a picture at the top of page 355 in your Egan's book. And it looks like this. Looks like this. We're getting ready to diagram out the electrical pathway, which is a lot less than the pathway of the blood. It's not that much. Very simple, but you need to memorize it. All right? Let's see here. All right, so looking at this heart, the first spark that comes from nobody knows where, the creator or whatever you want to say, the first spark comes to the SA node, the one at the top, number one. The SA node, which is the sinoatrial node. Okay? The SA node is the first beginning path of the spark. Okay, SA node. Then that spark fires down to the AV node. All right. So this is the SA node right here. That spark that starts here shoots down to the AV node. Right? Then the AV, it goes from the AV node to the bundle of His. From the bundle of His down the left and right bundle branches, all the way down, and then to the Purkinje fibers. These little fibers down here. These are what make the ventricle do that. The electrical, it's like having a plug. You got it plugged in on one end and you cut the other end and fray the wires, right? If you have some bare wires on a plug that's plugged up and you touch somebody, it's going to shock them, right? Same things happen with this. You start with the SA node, which is the sinoatrial node. That spark then jumps to here, which is the AV node, the atrioventricular node, right? Between the atria and the ventricle, right? And then it goes to the bundle of His, kind of like a little substation, okay? From the bundle of His, it goes down the left and right bundle branches. This branch here and this branch over here. After it does that, it goes to these fibers here called the Purkinje fibers. And that's what causes the jerk, okay? Depolarization. Now, not only are the Purkinje fibers doing something, but the cells of the heart are also doing something. Got to be working together. This is where those electrolytes come into play. Okay, here in a minute. So this is the flow of the electrical conduction of the heart. SA node, AV node, bundle of His, left and right bundle branches, and then Purkinje fibers. That's it. That's it. Now, what you need to know about the SA node is that it's called the pacemaker of the heart. Okay? The SA node keeps the heart firing at a normal rate. The normal heart rate, now you need to make sure you got this normal down. The normal heart rate is 60 to 100 beats per minute. That's the normal heart rate. 60 to 100 beats per minute. So if I ask you, what's the normal heart rate? 60 to 100. Anything less than 60 is bradycardia, which is slow heart rate, right? Bradycardia is any heart rate less than 60. And a heart rate that's greater than 100 is called what?
Tachycardia.
Tachycardia. Tachycardia is heart rate greater than 100. So the SA node is considered to be the pacemaker of the heart. Okay, that's the pacemaker of the heart. So it's going to fire at a rate of 60 to 100. That's what its job is in life. It's just a fire, fire, fire all day long for the rest of your life. It fires at a rate of 60 to 100. As long as it's healthy, that's what it's doing. Now, the AV node is considered to be the backup pacemaker. If the SA node is not working or is diseased or is out of commission, then the AV node will then be the backup pacemaker, except its rate is 40 to 60. So if your SA node is not working and you're living only on your AV node, you're going to always be a bit bradycardic, okay? So if the SA node is not working, the AV node will take over, but only at a rate of 40 to 60 beats per minute. So what kind of procedure do people get if their SA node doesn't work?
They get a pacemaker?
Pacemaker. That's what a pacemaker is for. Somebody's SA node is not firing like it should. So we get a pacemaker in place that will fire, fire, fire at 60 to 100. Okay. All right. Once it goes from the AV node down to the bundle of His, it will then go down the left and right bundle branch. Hope you're looking at it. And then down to those little Purkinje fibers that look like little frayed wires. Okay. That is the electrical conduction of the heart.
I don't know if this matters, but what is the normal pulse?
But what?
What's the normal pulse? Like, what is your pulse supposed to be?
60 to 100. Your pulse is your heart rate. Your pulse is every time your ventricles contract, that's your pulse. That's your heart rate. Heart rate and pulse, the same thing. So the normal pulse is 60 to 100. Normal pulse rate. Now, the pulse is also indicative of it could be thready, it could be real light or really bounding, right? So they talk about the pulse when they talk more about how it's palpated. But the pulse itself is your heart rate, okay? But if it's really, really hard, like your radial pulse is just thumping, that lets me know if your pulse is bounding, you probably have a high blood pressure, okay? Or if your pulse is real light and thready, I barely can feel it, then you probably have a low blood pressure or hypotensive. All right, so let's look at some of the PowerPoint. Well, let me see what's on this after this. Then we'll go to the PowerPoint. Make sure you write this down. The pathway to stimulation, of course, SA node, the sinoatrial node, gives us a rate of 60 to 100 beats per minute, referred to as the pacemaker of the heart, what I just said. And then the AV node is the atrioventricular node, also known as the junctional delay. The AV node is also known as the junctional delay, and it delivers impulse from atria to ventricles, right? And it acts as a backup pacemaker at 40 to 60 beats per minute. Then where does it go? Bundle of His. So the SA node to the AV node to the bundle of His. The bundle of His divides into the left and right bundle branches. Kind of like a little spot, little waist spot. Then it goes down the left and the right bundle branches. And then finally, the Purkinje fibers, which dispense the electrical impulse to the muscle. Now, this last one says vagal nerve stimulation of the parasympathetic nervous system can slow down the heart rate. What that means is you're going to learn when we get to pharmacology that there's a sympathetic nervous system and a parasympathetic nervous system. The parasympathetic nervous system can drop the heart rate, okay? And vagal nerve stimulation is, put it like this. If you ever have a baby and you are bearing down and push like that, or if you're on the toilet trying to push out feces and you're bearing down real hard, some people fall out like that. You ever heard of somebody falling, dying on the toilet? Okay, especially if they're older or if they have cardiac issues. Well, that's called vagaling down. When you push down like that and you become real negative, you're pushing, you put a lot of positive pressure on your midsection. You burn down real hard. Well, that makes your heart rate drop. Okay, that's what's called vagal nerve stimulation. Makes the heart rate go down. So if somebody's heart rate is real fast and you're trying to get it down for them, you can tell them, okay, try to burn down like you're having a bowel movement. Sometimes that helps the heart rate come down some, okay, because you don't want it to be really high. It can go into some deadly rhythms. So you try to do a lot of things to try to help them get that down into the paramedic, or you can get to the doctor or whatever. But vagaling down is when you bear down like you're having a bowel movement, and it makes your head get light because your heart rate drops. Okay. That's why having children is not for 80-year-old women. Okay. It's for younger women because you can take the bear down during childbirth. All right. We've gone over these, but you can write them down. Systole is the contraction, aka squeeze, aka depolarization, right? Diastole, aka relaxation, aka diastolic number. Tachycardia. Somebody just told me that there's a heart rate greater than 100 is tachycardia. And somebody else said bradycardia is a heart rate less than 60. All right. All right, so let's see what's going on in the cells during depolarization and repolarization. What's going on at the cellular level? Trying to see if it's in my book right quick. All right, what's going on at the cellular level? Okay, let's look at it in the PowerPoint. Yeah, here it is. All right, let's share my screen. Again, this is the picture of the electrical conduction, right? This is in words right here. And then this is the actual picture. The SA node fires over to the AV node, to the bundle of His, then down the left and right bundle branches into these Purkinje fibers. Okay. Now, let's see what's going on during depolarization at the cellular level. Okay, at the cellular level, we're going to look at the heart in several layers. We looked at the physical layer, with actual looking at the heart and seeing it squeeze, right? And then we look at it as the digital level, was the actual waveforms that we see, right? And now we're looking at it, I'm going to look at it in the cellular level. What's happening in each individual cell or myocardial cells, okay? The myocardial cells, which is the heart muscle. We get a couple colors here. Brown for the cell. We use purple for potassium. Okay. All right, so this is the cell. This is what's happening cellularly. So the myocardial cell is rich with, let me put this computer up on another level so it's easier to see. I don't know if y'all can see it or not. see it. Okay. All right, so that's the myocardial cell. All right, on the inside of the cell, which is, what's the word for inside the cell?
Intracellular.
Huh?
Intracellular.
Intracellular, good, intra. So inside the cell, which is intracellular. So intracellular is a lot of potassium. How do you spell potassium? P-O-T-E-E. I think so. Okay? Potassium. What'd you say?
K plus for potassium. I just use the elements, that's all.
You're going to see now why electrolytes are so important. Because intracellularly, there is a high levels of potassium. And extracellularly, there are, which is extracellular, which is outside, extra, is sodium, which is Na, I believe. Okay? So sodium is sitting out here. All right? This is what causes depolarization. Now, in a potassium-rich environment, sodium creeps in, causing an electrical imbalance. Sodium is called an influx. During an influx of sodium into a potassium-rich environment causes depolarization. An influx. See? Influx of sodium ions into a potassium rich cell causes depolarization. I'll give me some more markers. All right. Now, when this happens, the cell says, oh, you ain't supposed to be in here. You got to go. So once this depolarization happens and it squeezes, right, the squeeze of the cell pushes the sodium back out. Okay? So during repolarization, During repolarization, the cell pushes the sodium back out. So now you got the sodium coming out. Sodium coming out instead of going in. That deep, who is this trying to get in? That depolarization squeezes the sodium back out of the cell. And now we got sodium on the outside, potassium on the inside. The cell can now relax. Okay? That is so repolarization, which happens when sodium is pushed back out of the cell is repolarization. So when sodium is on the outside and potassium is on the inside, the cell is chilling. It's relaxing. But it has to happen. It's not saying it's bad. It's just if it doesn't happen. If you don't have the sodium, it can't go into the cell. There can be no depolarization, which means you have no heartbeat. Okay? So it's necessary to have the proper amount of potassium. Because what if your potassium is low? Hypokalemia, right? If it's too low, then when the sodium comes in, it might not be enough to cause a reaction. And so the depolarization is just kind of quivers or doesn't do it right. So what happens when you have a low potassium? You have muscle aches, cramps. It can cause arrhythmias. Arrhythmias is when the heart rate is not in rhythm, okay? So you got to have the right amount of potassium in order to react with the sodium. A lot of us have a lot of sodium and not enough potassium, right? All that salt and stuff that we take in, we have a lot of sodium on deck, but we don't have a lot of potassium. So that it's got to be an equal balance. If not, you don't have proper depolarization or proper repolarization, okay? So therefore, at repolarization or diastole, the blood pressure is still high because it's still a lot of salt, right? You can't get rid of the salt because you don't have enough potassium to make the reaction. So this is what's happening at the cellular level of your heartbeat. So not only do you hear the thump, thump, but you also know what's going on at the deepest cellular level of your heartbeat, okay? So that would be repolarization. Now, in our cells, we have what's called sodium channels and we have potassium channels. Little channels where the sodium can go in and out and channels where the potassium goes in and out. And then there's channels that have both of them can go in and out, okay? If you learned about the cell makeup back in high school or whatever, okay? That's how the sodium gets in, through a sodium channel. It's a channel that's made for sodium to go in so it can cause depolarization, push it back out. Now you have repolarization. You must have that or you don't have a heartbeat. Okay, you go asystole, right? Asystole is this. Somebody's heart rate looks like that. That's called asystole. A means without, systole, which is squeeze, right? There's no contraction, no depolarization, no squeeze, is asystole. That's one of your deadly arrhythmias. If you got this, you are dead. All right. That's what's happening at the cellular level. Now we're going to start talking about the digital, showing me the digital level, learning what the digital rhythms look like for the EKG. It's a lot of information. I know. Imagine if you missed today. Just so far, if you would have missed all of today, and we're not even through, right? And I didn't get a chance to record it, or you didn't record it, or whatever, you will be so far behind. That's why we tell you it's a lot. You got to be here. You got to be live or here. Okay? It's good that it's being recorded most of the time, so you can try to get it recorded if you have to, because we all have a life. But when you sign up for school, you got to understand that school has got to be up there with your life, especially this one, because it's such a fast-paced program. Okay? All right. Moving right along. So this is it right here for you to write it down if you'd like. If you notice here, we have these, we have a sodium channels here, potassium channel here, and this is what's happening during depolarization. Depolarization, aka contraction, right, is caused by intracellular influx of sodium into a potassium-rich environment. That causes a reaction. The sodium reacts with the potassium already present and changes and causes a change in intracellular charge from negative to positive. Thus, depolarization or contraction begins. What was that? Oh, some light went on. Must be that light bulb went out. Okay. All right. This contraction can be seen on the EKG or ECG as the P wave for the atria and the QRS for the ventricles. Okay, P wave for the atria and the QRS for the ventricles. Because not only is this happening when the ventricles do their thing, but the atria also have to contract. Same type of cellular stuff is going on. Okay, same type of cellular stuff is going on. All right, so let's look at repolarization. This is quite simple. Repolarization, aka relaxation, aka diastole of the heart. Repolarization, the electrical imbalance is restored by pumping the sodium ions out of the cells, which results in muscle relaxation. So you see this? Cytosol, that this is inside the cell. This is the cell membrane right here, right? And this is outside the cell, right? And what happens is after those sodium was inside the cell and caused a depolarization, that sodium was shot out of the sodium channel or the sodium potassium pump. And now all the sodium is outside and all the potassium is on the inside. When that happens, we're chilling. Think of it as somebody coming into your house at night. You and your family are in the house and a couple of burglars get into your house. If they get into your house, they're going to cause a reaction, right? You're going to react and cause furniture to be moved, right? Now, after that, you take care of business and you put them out of your house. Once the burglar's on the outside and you and your family's on the inside, now you can relax. Okay? This is what's happening in your cells.
So, Mr. McCarthy, just to make sure I understand,
Okay.
you said this is happening in our cells while we're taking the blood pressure or just constantly?
Constantly. Every beat of your heart. If this doesn't happen, your heart does not beat.
Okay.
This is what's causing your heart to beat. Every beat. Been happening since you were born, and it's going to happen until you are dead. In and out, in and out. Sodium in and out, in and out, in and out. All day long, every day. That's why it's very important to have your electrolytes. Plenty of electrolytes. If you're not a person who likes to drink a lot of water, or somebody who does not like, I don't like bananas, or I don't eat vegetables, they have a low potassium level. And they probably have arrhythmias and heart issues that they might not even know about. Okay? Usually something else causes you to go to the hospital, and then this rears its ugly head once you're down. Okay, a lot of things come about when you're down. When your body has been knocked down, then everything that was wrong with you comes to the surface. All right. So you need to make sure you're healthy as you can be. Be careful what you're putting into your body, and make sure your nutrients, your vitamins, and your electrolytes are on deck, because this is what's causing your heart to beat. Cigarette smoking, blunt smoking, pill popping, all that stuff will affect this right here. It's not worth it. So that is repolarization. All right, so let's look at the EKG. Let's take another 10-minute break before we get into EKG, because I don't want to do this for 5 minutes and then have to take a break. We're going to take another 10-minute break. I'm going to pause it. It is 45 after. Come back at 50 after, 2:50, and we will continue on with the electrocardiogram tracing. ECG, also known as EKG. This is also going to be in your book. When you come back, open up your books to page 360. Your Egan's book, page 360, and we're going to go through a couple of pages of EKGs. Reading these EKGs, what they look like. See you in 10 minutes. Okay, guys, it is now 2:50. We are back. Now we're going into the actual digital explanation of the heartbeat, okay? The digital aspect. And that is called a electrocardiogram, also known as an ECG or EKG. Same thing. They use ECG a little bit less than they use EKG, okay? I don't even know why they changed it, but no big deal. All right, it's the same thing. Now, let's learn the components of an EKG. Okay, what are all the components of the EKG? Right? So let me pull up my board. All right, components of an EKG. Let's make one.
Can you bring your screen up a little bit?
Yeah, I will. All right. This is the typical electrocardiogram, also known as the EKG. This is the P wave, Q, R, S, T. The P wave is atrial depolarization. Atrial depolarization is the P wave. The QRS is the ventricles. Depolarization. And the T wave is ventricle repolarization. I don't want to interrupt that. P Q R S T. P Q R S T. P Q R S T. Right? Same thing. P Q R S T. P Q R S T. That is our basic EKG. Okay? When the atria when the atria depolarizes, it's the P wave. When the QRS depolarizes, it's the ventricles depolarizing. The T wave represents the ventricle repolarizing. See, after the ventricle contracts, it's got to relax. The T wave is when the ventricle relaxes. Okay? And that's what happens. This is what you call normal sinus rhythm. Normal sinus rhythm. That look funny. Normal sinus rhythm. Now, what sinus means, guys, sinus means it has all its parts. It has a P, QRS, and a T. As long as your strip has P, QRS, T, P, QRS, T, it's sinus something. Okay? It might not be normal sinus, but it's sinus. Sinus means it has all of its parts, the P, the QRS, and the T. You want to learn that some rhythms don't have some of those. Some rhythms don't have a QRS. Sometimes it drops. There's there, and then all of a sudden it's not there, right? Some of them have extra P waves, right? Or it may have a QRS that comes out of place. That's what we're going to talk about. Now, as long as this is 60 to 100, it's considered normal sinus rhythm. Because what's the heart rate? Normal heart rate? 60 to 100. So as long as it's 60 to 100 beats per minute, it's considered normal sinus rhythm. What if this heart rate was 110? What would it be called?
Tachycardia.
What kind of tachycardia? If it's got all of its parts, sinus tachycardia. If it's got all of its parts, guys, and it's fast, then it's sinus tachycardia. So if it's greater than 100 and has all its parts, it's called sinus tachycardia. So if the heart rate is greater than 100 beats per minute with all parts, it's called sinus tachycardia. If the heart rate is greater than 100 with, remember that C with the line over it means with. All right, you got to know that. All of its parts, the P, Q, R, and the T, then it's sinus tachycardia. if the heart rate is less than 60 beats per minute with all parts, it is what?
Brady tachycardia.
What?
Bradycardia.
Good. What kind of bradycardia? It has all its parts.
Sinus bradycardia.
There you go. Sinus bradycardia. That's the only thing sinus means. Sinus means it has all its parts. Now you need to get your book, look in your book so we can find out, well, how we know what it is. I can't tell what the heart rate is by looking at that. You're right. That's where you come with EKG paper. The EKG paper, which is that grid, red and white, like picnic table looking paper. Okay? That's EKG paper. And that's how the EKG technician will be able to determine the heart rate and other issues with the EKG. Now, as a respiratory therapist, all you need to know is be able to note, identify different rhythms and heart rates. You don't have to say, well, I think he's borderline this and he's going into borderline that. That's for the cardiologist to do. We're not cardiologists now. We're not going that deep. I thought I had some sinus papers. All right. Thought I had some EKG paper. It's probably some over there. You'll see it when we come in the lab. Now, when we come to lab, guys, we got to do blood pressure, pulse. We got to do EKG. That's a lot in them little 3 hours. And take a test. So that's why you have to be on time. The test is going to start. You're going to knock it out, complete it. When the last person completes it, we're going to go over to the lab and knock out the lab. Then you can go home, okay? You'll be done. All right. No, they're on different days. It's in this first lab is Tuesday. All right. All right, here we go. So let me share my screen and go back to the actual note-taking guide. Or my PowerPoint. Then we get into that. So here it is. This is the electrocardiogram, ECG, also known as the EKG. You notice here it has those same things we talked about. You got the P wave, QRS, T wave. Okay, this is a normal sinus rhythm. All right. And now we got to figure out, how do we know how fast a heart rate is? All right. Now, this just talks about the parts of the EKG. I told you that already. The P wave is atrial depolarization. That's when the atria contract. Okay. The QRS is when the ventricles depolarize. And the T wave is when the ventricle relaxes. People are going out the house. You done got the people out the house now. All right. Now, I like to find ways to help people remember stuff. If you can figure out a way, because remember we said when sodium comes in the house, when the burglars come in, there's a reaction. There's a contraction going on, right? Furniture being moved, smoke in the city, whatever, okay? And you're going to then get rid of those burglars. And when they are outside and you and your family inside, you can then relax, all right? So if you want to think of something with QRS means, I don't know, something, and that means the reaction that's going on when they come in your house or they get in your face or whatever you want to come up with. That'll help you remember what the other ones are, okay? Because a lot of students have issues with remembering when they say P wave represents what, like, dang, I forgot, right? That's be easy question. Those would be an easy 100 on them. Okay, but you got to, sometimes you have to come up with different little algorithms or whatever. I forgot what they call them, but you come up with one of those to help you remember. Okay. Now, the interpretations, that's what we can ready to start doing, some interpretations. So I can look at an EKG and tell you what it is. So before I get to that, we're going to find out how do we count these rhythms. All right. Everybody look at the R on my screen. Right here, the R. Now, one way to count a rhythm is to see how far or how many small boxes are in between the R's. Everybody look right here. You see this from here, this right, this is a large red box. This is called a large box. These little ones are called small boxes. Really simple, right? You got, but it's, see, on the paper it's smaller than this, so it's hard to see. But now that this is magnified, you can see you have large boxes and you have small boxes. Okay? Now, to count the rhythm or count the rate of a heart rate, we can look at the boxes. How many these big boxes are in between R waves? Okay? So let me see if I can find it in the book. I know if here it is right. Look at page 358 in your book. 358. On the left-hand side, it's got a little space that says 2 large boxes, 4 large boxes, 6 large boxes. See that? Where your book at? Yeah, you need your book out. Your Egan's book. Look in your book on page 358. It's going to look like this. It's got a little section that says 2 large boxes, 4 large boxes, I think 6 large boxes, right there. See that? This is the surefire way to count the rhythm, count the heart rate. Now, what they're trying to say is this. Everybody look at my laser. One large box, if there is one large box in between the R waves, that heart rate is 300. Okay? 2 large boxes is 150. 4 large boxes would be heart rate of 75. And 6 large boxes will be a heart rate of 50. So what they're doing is each large box represents 300. Okay, so if there are 2 large boxes, you take 300 divided by 2, which is 150. If there are 4 large boxes, you take 300 divided by 4, which is 75. Okay, so if you look at page 358, that's the formula right there. You need to make sure you highlight that in your notes. 358 on the left-hand side. You don't have your book? Oh, okay. 358 on the left-hand side. Here, you look right here. All right, so let's look at it. Look at my pointer right here. Now, trust me, guys, the R is never going to fall right on the the large box. It's never going to fall right here, right here, right here. It's very rarely whether you get lucky enough for it to fall right on the large box. So what you have to do is just go as far as you went on this one to this one, and that will be considered one large box. Okay, so look at this. How many small boxes is this R wave into the large box? From here to here, how many small boxes is that? 1, 2, about 3, right? Okay, so to find out how many large boxes are in between R's, you got to do the same thing on this side. So 1, 2, 3. So that R wave would have been about right here. If that next R wave hit right here, that is equally to 1 large box. Everybody see that? It's not going to start right on the big one for you. It ain't going to give you that much love, right? If it did, like if it was an R wave right here and an R wave right here, that's 1 large box in between the 2 R waves. But since the R wave hits, it's going to hit anywhere in here. This one happens to hit right here, about 3 small boxes in. So you got to do the same thing over here. 1, 2, 3. So the other R, if it was right here, that heart rate would be 1 large box. And if there is 1 large box in between R waves, that heart rate is 300 beats per minute. Somebody is extremely sick. But I've seen it. This person is getting ready to go if you don't get them the medicine that they need. Okay? But in this case, it doesn't happen to be that because I don't even see the next R. It's way over here somewhere. Okay? I'm just trying to show you how you count the heart rate. If there is 1 large box between, see from here to here is 1 large box. Just like if it was landed on the line. From here to here is 1 large box. If there are 2 large boxes in between the R's, then it's 300 divided by 2, which is 150. You got your book at home? Mm-hmm. All right, let me see that. All right. So let's take that information we just learned, and let's look at the bottom of 359 together. Let's look at the bottom of page 359. You can see that looking at this one is not as focused or magnified as the one you just saw. But if you look at it, you can see the large boxes and the small boxes. Okay? Does anybody not see the difference between the large and the small boxes on the bottom of 359? Okay, so everybody can see it. All right. First thing I want to know is this rhythm sinus or not? All right, so I'm going to see if it has all of its parts. It has all right, P, QRST, P, QRST, P, QRST, P, QRST, P, QRST, right? So it's got all of its parts, so we know it's sinus something, all right? But we want to know how fast is it going. So using that technique you just learned, let's look at the R waves. R waves are the ones at the top, right? So starting with, you can just look at any 2, right? Let's look at this R and this R. Do y'all see these? This is a large box, large box, large box, large box, large box, right? So, and then the little bitty ones are the small boxes. So counting from this R wave to this R wave, how many large boxes do you see? Put it in the chat privately to me. How many large boxes do you see? Now remember, it doesn't always land right on the large box, so you might have to scoot over and go from that point to that point all the way through. That's why they use that little compass thing. The EKG techs, they use the pencil and the needle so they can spread it open. I forgot it's called a retractor or protractor or something. And they put it in between the R's, and that way they can turn it and see how many it is, because it's hard to try to guess it, okay? But if I'm looking at it, let me count again, because I don't forgot. Let me see. Here will be 1, 2, 3, 4. Okay, let me look at the good, Cassidy. Good, Michael, and it's about that. It's a little bit more than that, but that's close enough. Good, Talisha. Some more people to tell me how many large boxes do you see. Now, if you don't have your book, just text me, say, I don't have my book. because I'm waiting on as many people as I can to respond. Courtney, it's not that much. It's a little less than that. A little less than that. It's not exact, guys. Sometimes you have to see if it's a little bit more. You can kind of torque your little number a little bit, okay? Or tweak your number a little bit. But for the most part, let me see, I got Stephanie, good, Cassidy, Michaelin, Talicia, Courtney, okay, Kelsey, good. So it's about 4 large boxes. It's about 4. So when we count them, because when you look at it, the first one is a little bit past the main large box, right? So you have to go a little bit past the next one, that's 1. A little bit past the next one, that's 2. A little bit past the next one would be 3, and a little bit past the next one is 4, and this may be like one more small box past that, so that's okay. It's about 4 large boxes. So 4 large boxes 300 divided by 4 is what? 75 beats per minute. So this one's probably a little less than 75 since it's a little bit more past it. So let's look at the bottom down there. Electrification of normal sinus rhythm. Oh, it don't say, does it? Okay, it doesn't say. So this one's probably about 75 or maybe 70 to 75 beats per minute. So that will be a what? Normal sinus rhythm. Because first of all, it's sinus because it has all of its parts. So we know it's sinus. And if the heart rate falls between 60 and 100, then it's normal sinus. Okay? So this one is a normal sinus rhythm, and that's what they said. Look at what it says. Electrograph tracing showing a normal sinus rhythm. So it says it down at the bottom. Normal sinus rhythm. It has all of its parts, and if you look at the R waves, they are about 4 large boxes between them. And it says over here, if it's 4 large boxes, it's about 75 beats per minute. Now, that's the most accurate way to count them. But thankfully, they give us a trick at counting them. Now, what you can do is count the R waves and multiply by 10. But that's only if it's a 6-second strip, right? A lot of people mess that up because they'll see an EKG wave and they'll count the R's. Oh, it's 7 R's, that's 70. But if the question does not tell you or specify that it is a 6-second strip, because these strips come out of the machine and they encompass time. They may be 10 seconds. It may be a whole minute strip. You don't know if it don't say it, right? So you can't assume that it's a 6-second strip. Granted, we mostly use 6-second strips to make it easier for nurses and doctors and RTs to know what the rate is, right? But that's not a guarantee. And the NBRC hospital wants you to make sure the question says it before you answer the question, okay? So you do not assume that it's a 6-second strip unless I tell you, this is a 6-second strip. What is the heart rate? Well, then you can just simply add the R waves and multiply by 10, okay? So if we count these R waves up here, 1, 2, 3, 4, 5, 6, 7, but there's 8 of them on here. Remember I told you it's probably a little bit more than 70, so about 75 to 80, right? So that's what I meant to say, 75 to 80, because they're not exactly on that line, right? And so some people wouldn't even count that first one since it's right at the beginning of the seconds. So that's why I say you're not sure. And they don't say that this is a 6-second strip, right? So I'm not for certain if it is or not, okay? So if it says the following EKG strip is a 6-second strip, then in your mind, you can say, okay, cool. I don't have to worry about no boxes. All I got to do is count the R's and multiply by 10, okay? But either way it goes, if we went to boxes or counter, it's still a normal sinus rhythm because it's 60 to 100, right? And it's got all of its parts, okay? Any questions on that right there? All right, go to the page 360. There's gonna be a few more. Page 360. The top is going to show sinus tachycardia. Sinus tachycardia. So now it doesn't say it's a 6-second strip, but let's assume that it's a 6-second strip. Then what would the heart rate be for the one at the top of 360? Put it in the chat. The one on top of page 360 on the left-hand side at the top. Put it in the chat what you think the heart rate is if it is a 6-second strip. Assume that it is a 6-second strip. Good, Stephanie. Good, Michaelin. Good, Cassidy. Assume that it's a 6-second strip. Somebody, yeah, come on, baby. On the table. Somebody put 60. That's a little low. Remember, I said if it's a 6-second strip, you count the R's and multiply by 10. Count the R's and multiply by 10. So it'll be way more than 60. We're looking at the one on page 360 at the top. So the answer is about 110. If you put 110, you were right. Right? So let's look at it. 110. Let's count the R waves. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 times 10 is 110. Right? That is, and it has all its parts. It has all its parts, so it's sinus, right? But it's 110 beats per minute. So that's sinus what? Sinus tachycardia. Good. Sinus tachycardia. That's how this works, guys. Now, if you were to look at the boxes, what if it wasn't a 6-second strip? Let's look at, just pick any two R waves and count how many large boxes are in between the R waves. So I'm going to pick one. Don't forget, if one is over a little bit, then you have to go over to the next one a little bit to count as one box. So just pick two and count them. Here. So put in the chat about how many large boxes do you see between R waves. Just put it in the chat. Good, Kelsey, good. It's a little bit more than this, almost like that and a half, right? Yeah, about that, not in a half. Yeah, about 2.5. You're right, Michael. It's about 2.5. It's almost 3, but not quite 3, right? Not quite 3. Now, what did it say if it's 3? 300 divided by 3 is what? If there's 3 large boxes, then it said 300 divided by 3 will be what? Y'all can say it out loud. Just say it out loud.
100.
100, right? So since we know that 3 large boxes will be 100, it's not quite 3 boxes, right? It's about 2.5. So it's a little bit more than 100, right? Because it's not exactly 3 boxes. The less boxes, the higher the rate. Okay, so it's a little bit less. So you could, it'd be hard to guess that. You said 100, somebody said 110. Oh, you wrong. I'm not going to do it like that. This is just trying to get you in the act of being able to count them. Okay, being in the act of being able to count them. So since it's about 2 3/4 of 3 boxes, that's about 110. Okay, it's a little bit more than 100. All right. And if you read further, it'll tell you how many beats in every small box represents point something seconds and all of that. We don't have to do all of that. We're not going that deep with it. Okay. But that is sinus tachycardia. Let's look at the next one. Let's look at the next one. If this was a 6-second strip, what would this heart rate be?
40.
40. 40 beats per minute, right? Because it's only got 4 R waves. So if it was a 6-second strip, see? 1, 2, 3, 4. If this was a 6-second strip, and you might could say, well, maybe that other one's about right there, so it's probably a little bit more than 40 or whatever, but 1, 2, 3, 4, heart rate about 40 if this is a 6-second strip. All right, now let's look. Does it have all of its parts? It has a P, QRST, P, QRST, P, QRST. So since it has all of its parts, it's considered to be what? Sinus.
Sinus.
And so it's sinus and the heart rate is less than 60. So what's the whole term? The whole term. There you go. Sinus bradycardia. See? Sinus means all of its parts. And if the heart rate is greater than 100, it's sinus tachycardia. If the heart rate is less than 60 but has all of its parts, it's sinus bradycardia. Okay? All right. Now, now we're going to get into what's called arrhythmias. That means no rhythm, right? They're not in rhythm like they should be, okay? The R waves, when you count those R waves, they should be the same amount of space all the way through the EKG, okay? If they are not the same distance between each set of R's, then it's called out of rhythm or arrhythmia, okay? If the R waves are not the same distance all the way through. So for instance, if you got 3 large boxes between these 2 R's and then 1 large box between the next 2 R's, that ain't a rhythm. That is called an arrhythmia, okay? That is called an arrhythmia. That means a rhythm means no rhythm, right? Arrhythmia. The R wave should be the same amount of space in between them all the way through the line, okay? If they're not, it's out of whack. We use the R to R interval. That's called the interval. The interval between R and R is called the R to R interval, okay? Now, not only do we use the R to R interval, but we also measure the PR intervals, okay? And I'm going to have you measure them, but I do want you to be able to notice them when you're looking at an EKG strip. For instance, from here to here is called the PR interval. All right. And then from R to R would be the R to R interval. And then we have what's called an ST elevation. So here to here, from here to here, boom. This is ST segment. Elevation. All right. So from P to R. So from the P wave to the top of that R wave, that space here is called the PR interval. It should be the same all the way through, right? However many small boxes are in between here to here, it should be the same all the way through your EKG. If it's not, like say you have a PR like this, and then the next one is real close, then the next one is real far, then the next one is real close, real far, that's arrhythmia. There's no rhythm. It should be the same all the way through. The P to R interval should be the same all the way through. Just like the R to R interval. It should be the same all the way through. That's why EKG techs and doctors use that little compass, whatever you call it. I think it's called a compass, where it has a point and a pencil. And you spread it out, and it shows you how many small boxes that you're spreading, and they just turn it to see if it's the same all the way through. We ain't doing all of that. But you do need to be able to notice when you have a arrhythmia. You say, well, damn, that PR interval is super far away, but the next one is real close. So that's an arrhythmia, automatic, okay? Then you also have what's called ST segment elevation. So from here, I don't know if you can see that line good, but from there to there, that should be a certain length, okay? Whenever this ST elevation or segment is elevated, that is a sign of a heart attack. If somebody's ST segment is not regular, but like way up here, then that means the person is either having a MI, which is a myocardial infarction, heart attack, right now, or they've had one in the past. Once you had one, your ST segment will always be elevated for the rest of your life, okay? Because what it's reading, guys, is the electrical current, right? It's reading the electrical current from left to right. So when they put the stickers on you, those stickers are reading the electrical current. And it's showing you what's happening from left to right, what's happening in the heart. And that's what it shows. PQRST, PQRST, PQRST. So it's like this. Atria are the P's. PQRST, PQRST, right? PQRST, PQRST. That's what's happening. That's what we're reading, okay? And so once you have had an MI, a myocardial infarction happens because blood flow was blocked to one of your muscles, your ventricle, okay? And what happens is you have what's called, because I don't want y'all wondering, what are these? This is the coronary artery. The red one is a coronary artery, and the blue one is the coronary what? Vein. Same situation. Veins are deoxygenated, arteries are oxygenated, except for the pulmonary artery and the aorta, right? I mean, the pulmonary artery and the pulmonary vein, I'm sorry. Now, so you have a coronary artery and you have a coronary vein. If one of these coronary artery parts becomes blocked with your chitlins, right? For instance, if you have a blockage right here, then guess what? Blood can't get to this part of your heart. If blood can't get right here, it dies. That's a heart attack. And it's going to let you know it, right? Oh, and you're going to fall out because your heart muscle has died right here. Now, what we can do is go in and put a stent in here, right? Either bypass it by making another artery go from here and go around the dead part to here, right? Or around the blockage. So from here, go around that blockage and then go here, then you can get function back, but it'll never be the same. It'll always be a higher ST segment because it's taking longer for it to get across because you have, it's like it's jumping over a dead spot. And that's what you can see on the EKG. Okay, so you have to have clear arteries. When these arteries are clogged, that's what causes a heart attack. Okay, and we can go in and either open it up with a mesh and let blood go through, or we can bypass it. So if you heard somebody say he had quadruple bypass or double bypass, I mean, we had to bypass 2 of his coronary arteries or 4 of them, right? Or they put a stent in, is which they have your arteries closed like that. They put something in like this and blow it up and then take it out. and leave the mesh in there that holds it open for the rest of your life. That's a stent, okay? So that's what's happening in your heart. That's why I say watch what you eat. Now that you're learning so much about your heart, please take care of it better, because I'm sure you have not. That's what most people don't, right? If they did, McDonald's would never have another person in the drive-thru. Simple as that. All right. Moving right along. So an arrhythmia is when you have chaos going on. There's not rhythm, right? And so the first arrhythmia is at the bottom of page 360. Let's look at what it says for sinus arrhythmia. I'm gonna read. We're gonna do a little reading. In the book, at the bottom of page 360, the bottom paragraph on the left, it says sinus arrhythmia. To understand a little bit deeper, make sure you're doing your reading, because this stuff is in your reading. I can't go over all of it in one day. But for arrhythmia, it says, sinus arrhythmia is a common arrhythmia and is recognized by the irregular spacing between QRS complexes, right? The R's. Those R's are different. QRS is, they count it by the R's. The R and R is right here, and then the next one is like this. And then the next one is this close, right? There's irregular spacing in between. That's called sinus arrhythmia. Why is it sinus? Because even though it's not in rhythm, it still has what? All its parts. So if you look at the bottom one, it's still got a P, QRST, P, QRST, P, QRST. It's got all its parts. It's just that they're not in rhythm. So that's called sinus arrhythmia. If you missed today, you missed a lot. I want you to know. Sinus arrhythmia, like we said, is the most spacing is measured by identifying the intervals between the R waves of successive QRS complexes, which are normally consistent from one beat to the next. When the R to R interval varies more than 0.12 seconds throughout the rhythm strip and the EKG is otherwise normal, sinus arrhythmia is present. When you say, well, what's 0.2 seconds? Well, if you look at, that's what they're talking about with the small boxes. The small boxes. Or I think they're the large boxes. Or was it 2.2? Let me see. It said 0.12. All right, so yeah. Okay, so look at page 357 right quick, just so you'll see. Excuse me. They're showing you the time frames in here. The whole large box. So this is the large box, and these little ones are small boxes. Well, the whole large box is 0.2 seconds, right? The whole large box is 0.2 seconds. And the little boxes are 0.04 seconds, right? And so what they're trying to show you is they're saying that if the R to R interval, if the R to R interval varies more than 0.12 seconds, or if they're off by more than 0.12 seconds, then you have an arrhythmia. Now, you will never be able to look and say, oh, yeah, them R's is all 0.1, 0.3 to the third power, right? You ain't gonna be able to do all of that, and we're not expecting you to do that. But if you were to look at it and measure it, that's how you need to know at least how I would do it. If you wanted to sit down and look at a strip, you could figure it out, okay? But that's the most common arrhythmia, will be sinus arrhythmia. A lot of people have it. It can happen from different things. Electrolytes cause arrhythmias, all right? Electrolyte imbalances cause arrhythmias, all right? This arrhythmia may occur with the effects of breathing on the heart as a side effect of medication, as digoxin, as medicine called digoxin can cause arrhythmia. Most cases of sinus arrhythmia are benign and don't need any treatment, right? You may have a sinus arrhythmia and it just is what it is. You know, it don't even have any symptoms. You don't have any, you're not symptomatic at all, and don't need to go to the doctor and say, I'm about to die because I got a sinus arrhythmia, okay? Don't worry about it. What you need to know is sinus because it has all of its parts. Okay. All right. The next one on 361. Then we start talking about heart blocks. Okay. Now I'm not going to get into the blocks for RT210. You won't have to be able to tell me blocks. I can teach you later about heart blocks. You have type 1, you have a first degree heart block, then you have second degree, and you have a third degree heart blocks. And this is when you've had real bad situations, different sicknesses where the heart is being blocked, right? It's going from the SA node to the AV node to the bundle of His, but then it doesn't go down the left bundle branch. It goes straight from that to the Purkinje fiber or bouncing off, you know, it's a block. There's something that's blocking it and it can't see. And you can see that on the EKG. Oh, they got a first degree block or they have a third degree block. He pretty sick. Okay. He can't do nothing. He can't lay flat. He can't do no jogging. Can't get in the tub and lay back. Can't breathe. Right? You have people who can't lay back without feeling lightheaded or can't breathe. They got heart issues. All right. So we're not going to worry about the blocks. But we do need to get into a couple of more, some atrial issues. There are some atrial rhythms and there are some ventricular rhythms or arrhythmias. Atrial arrhythmias and some ventricular arrhythmias that you need to know about. The first one is a flutter, atrial flutter, which is on page 362, the second box on the left, which is figure 18-15. Figure 18-15 shows you atrial flutter. Now, atrial flutter, you should never ever miss it. It looks like a steak knife. Okay? It looks like the serrated edges of a steak knife. See that? This is atrial flutter. Look how pretty that is. It's a pretty one, right? But look how sharp the P waves. The P waves should not be that sharp. Those P waves are sharp, 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 and perfectly in tune or uniform. Looks like the edge of a knife, right? Looks just like the edge of a steak knife. Looks, them steak knives we got in our house, a little wood, old school, you know, that looks like a steak knife upside down, right? That's atrial flutter. So think of flutter cutter. Flutter cutter, because a knife cuts you, right? So the one that looks like a knife blade is the atrial flutter. Flutter cutter. I just thought of that. You can charge, I'll charge you a little later. Atrial flutter. Flutter for cutter. Okay? Looks just like a knife. Perfect. QRS. QRS. See, the QRSs are fine, but the atrial, the atrial is the problem. Okay? Atrial flutter. So let's look at atrial flutter. Michaelin, can you read the first paragraph for atrial flutter, please?
Atrial flutter is a rapid depolarization of the atria resulting from an atopic focus that polarizes at a rate of 250 to 350 times per minute. Typically, only one atopic focus is causing the arrhythmia, which causes all the P waves to have a similar or to have the same appearance. The result is a characteristic sawtooth baseline pattern.
Good. Stop right there. The sawtooth pattern is your atrial flutter caused by ectopic foci. The ectopic foci is kind of like a little monster that is in your heart. It's a little monster. When I was in, because I went to Concord, and when I was here in 210, you can mute your mic now, Michaelin. When I was in 210, our teacher explained to us about atopic foci, and it's kind of like little, just think of it like a little coronavirus. You know how the coronavirus looks, the little ball without a little spikes on it? Think of that, a little ectopic foci that's just around the heart. And sometimes they just whenever they touch the heart, it causes a contraction. And it's like it's out of place. It's not in line. He's just swimming around, finding a place to touch, right? And the ectopic foci will, and so ectopic focus is one, ectopic foci is several of them. But what happens is that ectopic focus will just run around in your heart, swirling around, and just touch your heart right there, then makes it contract. Touches the atria, make it contract, right? And the sinus, the SA node is not causing it, it's the ectopic foci causing it. So it causes a baseline sawtooth pattern. Okay? So that's what she's talking about when she said the ectopic focus. Okay? You don't have to remember about the ectopic foci, it's not on the test, but I want you to know that's what's going on. Just like a little demon that's in your heart floating around, and every time you touch something, that makes it contract. Okay, whether he's touching the ventricle or making the ventricle do something, or he's touching the atria, making it do something. All right, that's atrial flutter. What you need to know is that it is a sawtooth pattern. Flutter the cutter. Okay, flutter the cutter. All right, you notice that the QRSs are fine, but the P waves are funky looking, right? P waves are funky looking. T wave is too. Now, look at page 363. This is called atrial fibrillation. Oh, well, this time the atria are not beating, they're just doing this. The ventricle is contracting, but the atria is just quivering. See that quiver? If you look at it, you see the P waves just kind of wiggling. See that? These P waves, P waves just kind of quivering around. They don't look together at all. Look at that. Just a little quivering. QRSs are good, but there's quivering, right? Quivering. And also, what do you notice about the R waves in this one? Are the R waves in wriggle?
No, the tips look rounded.
Yeah, well, I'm talking about, okay, the P waves, yeah, they're rounded and they're just quivering. They're not a definite contraction. It's just kind of like a shake. They're not really contracting, they're just kind of shaking, okay? It's not deadly, but it ain't good either. But what I'm talking about now, not only are the P waves messed up, this is atrial fibrillation, but look at the R waves, these R waves. Different spaces. They're not in rhythm. Mm-hmm. Look, from here to here is a space, but look from here to here. That's a long space. See, that's not rhythm. That's out of rhythm, right? That's an arrhythmia. So not only is it that type of arrhythmia, but it's also an atrial issue. This is called atrial fibrillation. It's just fibrillating, like it's cold, right? Like when you're shivering when you're cold, that's what the atria are doing. Shivering. Atria just shivering, called fibrillate, okay? Fibrillation. They're just shaking. The ventricles are contracting, but the atria are just quivering, okay? That's called atrial fibrillation, okay? Now, look at, Michael and read a little bit of atrial flutter for us. Talisha, do you have your book?
I have my book.
Okay. Read a little bit of atrial fibrillation for us at the bottom of 362.
Atrial fibrillation is present when the atrial muscles quiver in an irregular pattern that does not result in a coordinated contraction. The baseline electrical activity appears erratic, and no true P waves are seen in atrial fibrillation.
Stop right there. Stop right there. That's it. All right. So good. So what she just said is that the atria are just quivering, and there's no really precise P wave. There's no definite P wave. It's just a shaking, right? It's just quivering. There's no coordinated contraction like where it's supposed to be, right? P wave and QRST, P wave, QRS, it's just anywhere. They're just all over the place. The atria are just shaking, okay? Quivering. That's called atrial fibrillation. That is two of the atrial rhythms. We call those atrial rhythms. When somebody's having a problem, they have atrial issues. Atrial flutter is the cutter, and atrial fibrillation is the shaking, quivering, right? Like it's cold. Okay? Those are only two arterial waves you need to understand or remember. Atrial flutter and atrial fibrillation. Those are arrhythmias, but they are not deadly. Okay? Non-deadly. The atrial issues are non-deadly. The only ones that are deadly are some of the ventricular arrhythmias, because that's what pumps the blood to the heart, to the body. If that ain't working, you ain't standing. Okay? All right. Let's look at one more before we break again. Let's go down to what's called Pvcs, which is page 363, right? The bottom one on page 363 is called Pvc, premature ventricular contraction. A premature ventricular contraction. All that is, guys, is a QRS out of nowhere. It is not where it should be. Let's look at it right here. QRS should be after the P wave, right? Let me scoop my screen up. The QRS should come after the P wave, right? It should be P wave, QRS, T wave. P wave, QRS, T wave. Now look, if I have another QRS that falls after this T wave, before the P wave, that's out of place. That's premature. It came too soon, right? Came too soon. Now, get your mind out the gutter, but if that's how you remember, that's how you remember. Now, P wave, QRST. The QRS should come after the P wave. If it comes anywhere else, it's premature. It came too soon. That's called a Pvc. All right? So if it falls after this T wave, before the P wave, it came too soon. It's supposed to wait. Now you came too soon. You're supposed to wait till the P wave come, man. You done came before the P wave. You too soon. Wait out there till he get here. Right? He's too soon. Okay? So that QRS come too soon, that's premature. Right? You'd be amazed at what my last class said to help them remember. But since we record, I'm not going to say it, but I'm sure you can think of it. Now, let's look at it. This is an example of a Pvc. Not only does it come too soon, but it looks bizarre. The QRS don't even look like a regular QRS. Sometimes it's upside down, it's fat, it just don't look right, okay? And it's out of place. That's called premature ventricular contraction, because QRSs are the ventricles, right? The QRS is when the ventricles contract or depolarize or squeeze, right? Now, let's look at it. If we look at it, starting from the left, you got a P, QRS, T. Then boom, what is that? That's another QRS. Came too soon. Came too soon. So we had a P wave right here. This is a little P wave, QRS, T, then bam, another QRS. Where you come from? It's too soon. Let's look again. P, QRS, T, P, QRS, T, P, QRS, T, bam, another QRS. Where you come from? Too soon, right? That's a Pvc. These are Pvcs. They don't look normal. Sometimes they're upside down. Sometimes they're real wide and bizarre looking. But the main thing is that they came too soon. Look, P, QRST, then bam, before the next P wave, a QRS came. He came too soon, man. You need to go back out and wait on the P to come first. Okay? That's a Pvc. Pvcs are not deadly unless there's a few things. Unless there's a lot of them, what we call multifocal, if there's a lot of them, or they land right by that T wave, then they can become dangerous, okay? But for the most part, Pvcs are not deadly. They can come from stress, medicines, things like that. But for the most part, they're not deadly, all right? Let's see who else we got with us, and we're going to take a break. Christian, do you have your book?
Yes, I do.
Okay. Read a little bit of the premature ventricular contraction, then we're going to take a break.
Premature beats can occur when a portion of the impulse conducting system or myocardium other than the SA node becomes diseased and triggers depolarization of the surrounding cardiac cells. Sources for the impulse outside of the SA node are called ectopic foci.
Stop right there. See, there we
Okay.
go again. There go that demon again. That ectopic foci. Now he floating around. He's not, like they said, the SA node is diseased. Things ain't working like they should. And that little foci monster is just floating around the heart, and he touched that ventricle. He just sit there and say, oh, I guess I'll touch it right now. I'm going to touch it right now. Every time he touches it, it causes a ventricular contraction. And if it's not in order, it's a PVC. Okay? Ectopic foci touches those atria for atrial rhythms, and it touches the ventricle to mess with the ventricle rhythms. Okay? Let's see. It might be a little bit more. Ectopic foci occur when tissue hypoxia, that's lack of oxygen, acid imbalance, acid-base imbalance. You want to learn about that. Or look at that. What's that next part say? Electrolyte abnormalities are present and cause the cardiac cells in the ventricles to become abnormally excited. PVCs are easy to recognize because they are usually unique and bizarre QRSs that are much wider than normal. Okay? So they come too soon, they look bizarre, right? And they can happen from hypoxia, they can happen from acid-base imbalances and electrolyte imbalances. So if you're not getting your electrolytes, you could be having PVC right now. You can't feel them, okay? Only time we know you having them is if we're looking at EKG, okay? And so if the doctor sees you got a few PVC there, we're going to then know what to check. Well, let's check his electrolyte level. Let's get a CBC with DIF and check the electrolyte level. Let's get an ABG and check his acid-base status, right? Check his oxygen level. Is his oxygen right? See, this is what our respiratory is going to be doing. Way more than breathing treatments, okay? All right, let's take a break. It's 3:55. Let's come back at 4:15. Give you a 20-minute break. Come back at 4:15, and we're going to wrap up for today. Yeah, right here. We only got two more that I want to go over. That's going to be VTAC and VFib, ventricular rhythms that are deadly. Talk about that. I'm going to pause the recording. We'll be back at 4:15. All right, guys, the break is over. It is now 4:15. A little bit more, and we're going to wrap it up for today. But I want to get as much in as I can, questions, stuff like that, because this is a lot. Again, like I said, just imagine if you missed today. If you would have missed today completely and it didn't get recorded, you'd be relying on the book and friends, right? And what I could do to try to find an old lecture or something, but it's a lot of information. I just say that to make sure you are live or here, okay? When I open up the doors for Alpha Group or Omega Group, if you can get here, you need to try to be here because it's so different when you're here, all right? And if not, at least live so that you can read and you can ask me a question and I can explain it, show it to you on the board, something like that, because your question may be the same question somebody else has but just didn't want to ask it. Please don't be scared to ask it. That's what I'm here for. There are no stupid questions, okay? I want competent therapists in my field, all right? So I'm going to make sure I'm here for you to answer questions. Don't worry about it. Don't be shy. Who cares what somebody thinks? This is your bag that you're securing. I got the bag, okay? I'm trying to give it to you. So don't be worried about what nobody says, okay? You can't be worried about that. Just ask your question, and we're going to get it understood as best as possible. This is your grade, okay? So I'm here. Now, let's finish up. Let's look at some of this that I put on here. So a couple of pictures of some of the stuff we've already gone over. vibrate. All right, so this is the normal sinus rhythm. We've done all of that, okay? All right, now, for those atrial rhythms we talked about, there's another one I want to add in here, and it's called a PAC, which is a premature atrial contraction. Now, very rarely do you see these, and it's very hard to tell between PACs and atrial fibrillation sometimes, depending on how many it is. But a premature atrial contraction, guys, is simply a early atrial beat caused by who? Ectopic foci, that old evil ectopic foci, okay? That's that little demon I talked about that's just kind of sitting around in the heart looking for somewhere to touch, right? And if he touches the atrial before it's time, then you're going to have an atrial contraction that's out of place, which is called a PAC, okay? PAC is a premature atrial contraction, and a PVC is a premature ventricular contraction, okay? So we have those little PACs. Then we talked about atrial flutter, so flutter cutter. That's the one that looks like the sawtooth pattern. You don't have to remember how many beats that it may be and all that. Just remember that atrial flutter is an atrial arrhythmia, okay? All of these are atrial arrhythmias, okay? It's an atrial arrhythmia that looks like a sawtooth pattern, all right? Then the other atrial arrhythmia we talked about is atrial fibrillation. Atrial fibrillation. The atrial fibrillation is when you have chaotic twitching of atrial tissue. They just kind of twitching, right? They're not contracting like they should. They're just kind of shivering or quivering, right? And they can cause a decrease in cardiac output because of impaired ventricular filling. So this is what they're talking about. The amount, whoever that would have just came in, mute your mic for me, please. Let's look at what we talk about cardiac output. When the left ventricle pumps blood to the aorta and to the body, that amount of blood is called cardiac output. All right? That's called cardiac output. All right? Okay. Cardiac output. That's the amount of blood that comes from the left ventricle to the body, right? And it should be 5 liters per minute. Cardiac output is signified as C.O equals 5 liters per minute. Now, to put that in perspective, let's look at let's look at these water bottles. Each one of these water bottles is 500 milliliters. So 1,000 milliliters is 1 liter, right? So this is 1 liter, right? 500 mLs and 500 mLs equals 1,000 mLs, which is 1 liter. This is 1 liter. Your heart pumps out 5 liters per minute of blood. So that's, look, this is 2 liters. This is 2 liters. Then you have to have another one be 3 liters, 4 liters, 5 liters. So 10 of these bottles, 10 of these bottles is how much your heart pumps out every minute. 5 liters of blood. And I only got 1, 2, 3, 4, 5 of them up here. So 5 more is what you would need, right? 10 of these. That's a lot of blood, okay? That's a lot of blood. That's your cardiac output. Now, what they're trying to say is if I have atrial fibrillation, atrial fibrillation can cause a decrease in my cardiac output, because if my atria are not squeezing the blood down to my ventricle, then it's not going to be that much coming out, right? If there's not a lot going into the ventricle, then there can't be a lot coming out of the ventricle, correct? So if we're looking at, this is my right atrium, right? This is my left atrium, and these are my ventricles. Well, if my left atrium is only just quivering, then there's no way for it to fill up my ventricle like it should, right? The blood should fill up my ventricle, and then my ventricle depolarizes to the aorta and then to the body. The amount of blood that leaves the aorta to the body is called cardiac output, and that should be 5 liters every minute. 5 liters, which is 10 of these. Every minute is pumped. That's a lot of blood. So what they're saying is atrial fibrillation can cause a decrease in my cardiac output, because if it ain't filling up, then it ain't that much for it to push through, right? You're going to also find out some other things that cause a decrease in cardiac output, okay? And always remember that volume is also synonymous with pressure. The more volume is there, the more pressure you're going to have, right? So if that volume or the cardiac output, which is it's a volume of fluid, right? A volume of blood. If that volume is low, then my blood pressure is going to be low. So that's thinking that if I get shot and I start bleeding internally or bleeding out, the blood is not going into my heart, it's bleeding out on the floor. So my blood pressure is going to drop, okay? That is why you fall out in a trauma. When somebody gets shot and they fall out, it's not because of the bullet. It's because of the rapid drop in blood pressure, okay? They all of a sudden, blood pressure bottom out, boom, you're gone, okay? It's not because the bullet did some kind of crazy that made you fall all back, and our bullets don't push you back and all that. They just drop you. And the reason why you drop is because your blood pressure bottoms out because your cardiac output is decreased, all right? Because you have opened up blood in vessels, and now the blood is filling outside or into your cavities inside your body, and it's not flowing through the heart. So if that blood is not there, the blood pressure drops and the patient dies, okay? That's why when somebody's blood pressure is low, we give them fluid. Not only do we give them medicine, but we hang what's called fluid. They give a bag of saline. Let's get a bolus of saline and push it in real fast to build up the fluid, the pressure, because fluid and volume is synonymous with pressure. The more fluid is in there, the more pressure is going to be, okay? So that's important that you know how to string those two together. Fluid or volume and pressure are the same. They are directly related. The more volume you have, the more pressure you have. Just like a balloon. If I blow a balloon up with 100 milliliters of volume, it's going to be some pressure on that balloon. But if I put 500 liters of volume in that same balloon, now I have increased the pressure inside the balloon. But if I take the volume out, the pressure of the balloon goes down. So volume and pressure are directly related, all right? So that's what they're saying is when you have an atrial issue and the atria are just kind of shaking, then they're not necessarily filling up the ventricle like they're supposed to, so you have a less amount of blood, which is a lower cardiac output, okay? So it can cause a decreased cardiac output because it's not filling up like it should, okay? But it's not life-threatening. Atrial rhythms are not life-threatening. So those are our atrial rhythms. Abnormal, don't worry about the abnormal P wave. Don't really worry about that. Just, you need to know PAC, atrial flutter, and atrial fibrillation. Okay? Not life-threatening. This is a kind of picture of it, of how they look. This is the EKG wave here. You got the PQRST, PQRST. and they're showing you what's going on. So notice the darker color. This is what's going on during the transfer. The P wave is the atria. See, atria are contracting. Atrial contracting, that's but you get the P wave. Then you have the ventricles contracting. When the ventricles contract, that's our QRS. And then when the ventricles recover or relax or depolarize, that's considered the T wave. When the ventricle relaxes, recovery, okay? Now this is kind of showing a normal heartbeat. Then this one will be a fast. See how it's got a lot of R's in there, so it's a faster rate. This is a slower rate, right? So a fast heart, 1, 2, 3, 4, 5, 6, 7, 8, 9, that's 90. So it ain't really too fast, but I guess they're going by the count. But that will be a fast heart rate. This is a slow heart rate. And this is irregular or arrhythmia. Look at these two R's right here, from here to here. But then the next one is from here to way over here. Then these look a little normal down here. But when they have them like that, the R to R or the QRSs are not in rhythm. That's an arrhythmia or irregular heartbeat. All right, atrial fibrillation. Now this one, I don't really like this picture, guys, because they got these spikes and it kind of looks like flutter, but it's not. This is when the atria are just quivering. See how they squiggly lines? They're just letting you know they just kind of quivering. And so you just got like a quiver. These should be a little more rounded. These little P waves should be a little more rounded. I don't like how spiky they are, but that's the picture they gave for atrial fibrillation. But this is atrial fibrillation, but just imagine these a little more rounded, not so spiky, okay? But the atria are just quivering. They're not really pumping, all right? And then atrial flutter will have you boom, 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 boom. Man, matter of fact, these should be a little more spiky, all right? But atrial flutter is when you have the sawtooth pattern, okay? Sawtooth pattern. PVCs, look at this PVC. You can tell this is a PVC. It's just out of nowhere, right? You got PQRST, PQRST, then boom, another QRS out of nowhere, right? That's a premature ventricular contraction. Also, another thing going on with this patient, look how high that T wave is. See how this T wave is? That, remember I said that ST elevation, that ST segment? This is the S right here, and this is the T. Look how this T is higher than the R. So this patient in their life has had a MI before. They've had a heart attack or they were having a heart attack right then, because that's ST elevation. This ST elevation is too high. This S should not be higher than the R wave, okay? And so that's just, but that's not what they're showing you here, but I'm noticing that as well, okay? But what they're showing you is after the T wave came another PVC before the P wave came, right? It's too soon. That's a premature ventricular contraction, PVCs. Now, let's get into a couple of the deadly arrhythmias. Ventricular tachycardia, VTAC. Write that down, right? VTAC, that's what we call it. We call it VTAC. That's on page 364 in your book at the top. VTAC is a deadly arrhythmia. Notice you don't have any T waves, you don't have any P waves. All you have is contract, 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 contract. All you have is a bunch of QRSs. Your heart cannot sustain that. You see this, you need to call cold blue. Okay? It's time to call cold blue. They need medicine and they need to be CPR. Okay? This is a deadly arrhythmia called ventricular tachycardia. Now, when you get a little farther in, there are some ventricular tachycardias that have a pulse and ventricular tachycardia that does not have a pulse, right? But we're not getting that detailed. For you, VTAC is a deadly arrhythmia. So if we look at the figure on 364, this is VTAC. Notice it's just a bunch of R waves. Bunch of R waves, bunch of QRSs. That's it. Now this one happens to be upside down, but that's okay. Sometimes they're upside down, sometimes they're not. But this is QRS after QRS, 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 QRS. This is a ventricular tachycardia. You can't mistake this for nothing. Okay? You shouldn't be able to mistake it for nothing. Now, ventricular tachycardia look at the second paragraph on page 363. At the bottom on the right side where it says ventricular tachycardia, I'm looking down at the second paragraph for us. It says sustained or symptomatic VTAC is a serious and potentially life-threatening arrhythmia because it indicates that ectopic focus is just rapidly firing from the ventricles. He's down there in the ventricles just causing a problem, just boom, just touching. And he's causing those ventricles to keep contracting. And they cannot sustain that. And then eventually going to start just quivering, which is ventricular fibrillation, right? And V-fib, you must defib. Defib means shock, okay? But we'll get on that in a minute. Ectopic foci is just rapidly firing from the ventricles, which results from increased automaticity. It suggests a significant pathologic defect in the myocardium and often leads to ventricular fibrillation because it can't sustain all that beating that hard, that fast. It's going to start just quivering, which is VFib, VF, which is immediately a life-threatening arrhythmia if untreated. And it says MI, coronary artery disease, hypertensive heart disease are some of the common causes of VTAC, okay? Causes VTAC. So VTAC is life-threatening, one of the life-threatening arrhythmias, but it's damn sure life-threatening if it turns into VFib, okay? VFib is automatically, they dead, okay? Because VFib is the same thing as asystole. It might as well be. That's what the question is going to ask you. VFib is physiologically the same as what? And your answer should be asystole, because if the ventricles are not contracting, they might as well not even be quivering. The blood is just sitting there. It's not pumping through the body. Patient is dead, okay? Patient is dead. So that's VTAC. Let's look at the VFib.
Can you repeat that one more time?
What?
About the fibrillation?
Yeah, VTAC, this right here, VTAC will turn into ventricular fibrillation because it cannot sustain that constant ventricle contract like that, okay? Once it turns into VFib, it's the same thing as cardiac standstill, which is asystole. It's physiologically the same because there is no pulse, because it's not contracting. If that ventricle is not pumping, then blood is not moving. And if blood is not moving, then you're not living, okay? When these ventricles are boom, 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 and go into VTAC, you need to hurry up and fix that because that's a deadly rhythm. But if you don't fix it and it turns into just this, if the ventricles are just doing this, then that's the same thing as nothing at all, okay? Because if it's not squeezing, blood is not coming to the body. So if they're just doing this, the blood is just sitting there. That's cardiac standstill. Same thing, okay? They're saying that's physiologically the same as asystole, which is cardiac standstill, okay? Because all it's doing is this. That ain't enough. That is life. They are dead, okay? They're physically dead. You got to get in there and CPR, medicines, shock, everything, okay? All right. So here goes V-fib. Now, people say, oh, is that A-fib? But no, that's V-fib. A-fib, you're going to see some QRSs. you're going to see squiggly P waves and then a QRS, squiggly QRS, right? But in V-fib, there is no P wave. It's just a bunch of squiggly ventricles. These are all QRSs, but just quivering QRSs. They're not contracting, they're just quivering. So this is V-fib. Same as at the bottom of 364. If you look at the page 364 at the bottom, that's V-fib, ventricular fibrillation. Ventricular fibrillation. They're just shaking. All right, let me see who we got here. Kelsey, are you with us?
Yes.
Okay. You got your book?
Yep.
Okay, start reading for ventricular fibrillation for us at the bottom of 364.
VFib is the most life-threatening arrhythmia and is defined as erratic quivering of the ventricular muscle mass. It causes the cardiac output to drop to zero. The patient becomes unconscious, and VFib represents a true medical emergency that results in the need for acute resuscitation. The electrocardiographic tracing of VFib shows grossly irregular fluctuations with a zigzag pattern. This pattern is caused by the same problems associated with VTAC.
Stop right there. Good. So when you see this, you definitely need to call Cold Blue. Start compressing because the heart is not pumping. She said cardiac output is at zero. Remember, we got 5 liters a minute going through the heart, and all of a sudden, nothing. Okay, so that makes it the same physiologically as asystole, flatline, because there is no contraction. It's just erratic quivering. That is the most life-threatening rhythm. Okay, that's the most life-threatening rhythm. You're going to have to give them oxygen. You're going to have to give them antiarrhythmic medicines. You're going to have to shock them, and cardiopulmonary resuscitation, which is CPR. Okay. All right. Now, there's one last rhythm that we'll talk about. It's not in the book. Well, not on in these pages, but there's one more rhythm we'll talk about, and it's going to add to your deadly rhythm. So there are 4 deadly arrhythmias. Make sure you write these down. There are 4 deadly arrhythmias. VTAC, VFib, asystole, and EMD, which is electrical mechanical dissonance. Here they are right here. 4 deadly arrhythmias. VTAC, VFib, asystole, and EMD, also known as PEA. PEA is pulseless electrical activity. What that's saying is, you look up on the monitor and you see this, a good, beautiful looking EKG. A beautiful EKG. But he over there with his tongue hanging out and his eyes closed because he has no pulse. He's dead. You can be dead, but the electrical function is still going on in your heart. So PEA is known as pulseless electrical activity, also known as electrical mechanical dissonance, same thing. Okay. What it is you have the patient has an EKG, a normal sinus rhythm on the screen, but they don't have a pulse. There is no pulse. That is a phenomenon. They can't really figure out how that works, but person is laying there dead, no pulse, but the EKG shows a perfect, beautiful, normal sinus rhythm. Okay, that's why you can't treat monitors. You treat your patient. Don't treat the monitor. You walk by, oh, Mr. Johnson, his sat look all right, his heart rate look all right. So bye, I'm going on to lunch. But he could be laying there dead, right? But of course, there's one alarm that's going to start going off that's going to bring your attention. That's going to be the respiratory rate, right? Because I mean, his heart rate is good, but that respiratory rate going to show apnea, right? And it's going to start alarming because he ain't breathing, okay? And so that's the 4 deadly arrhythmias. VTAC, VFib, asystole, and PEA, also known as EMD. Those are your 4 deadly arrhythmias. They're going to ask you this on your oral exam. What are the 4 deadly arrhythmias? You're going to have to remember it. Okay? Notice AFib, A-flutter, that ain't on here. Right? The 4 deadly arrhythmias, Pvcs ain't on here. The 4 deadly arrhythmias are these: VTAC, VFib, asystole, and PEA, also known as EMD. Okay? All right, almost done. So that's VFib. Here goes asystole. No beat at all, just a flat line. And this is the electrical mechanical dissonance, also known as PEA. It's showing it's a normal heart rhythm, right? That's a normal sinus rhythm right there, except they don't have a pulse. That's why when we're doing CPR and then, we give a shock or we give the medicine and we're doing ACLS, and then when it's time to do a pulse check, that's why we do a pulse check. Because if the doctor sees this, he or she can't say, oh, okay, we got him back, let's take him to ICU. No, they're going to say, hey, do I have a pulse with that? Right? And that's when you're going to start scammering, filling the carotid pulse and the femoral pulse. You're not going to waste time on the wrist. You're going to look carotid and down in the femoral pulse to see if you got some thump. If you don't have any thump, that's PEA. You got to keep doing chest compressions. Resume compressions. That's what they're going to say.
So if a patient has a pacemaker, would the heart continue to beat would you continue to feel the pulse?
I don't think so.
Elsewhere?
I think if they have when they have a pacemaker, their R wave will be have a little spike on it. We can tell when somebody's being paced because we can also pace them with the things. But I don't think it's going to beat, right? If they have a pacemaker, it's just going to show the electrical activity. It's going to show electrical activity, but you got to make sure you got a pulse with that. Okay. Yeah, good question. And I've never seen it with a beat, and just because of a pacemaker, I think it's just showing a little electrical impulse that you'll see, but you won't have a pulse if they're dead. Yeah. All right. And finally, the normal sinus rhythm. Notice how I put the same one for normal sinus rhythm and electrical mechanical dissonance, right? It looks the same. The only difference is a normal sinus rhythm, they got a pulse. For the EMD, which is electrical mechanical dissonance, also known as PEA, is pulseless. It looks good, but it doesn't have a pulse. Okay. Now, these are those, just for your notes are concerned, those ventricular arrhythmias. We had the Pvcs, which are premature ventricular contractions. Remember, we read about them already, talk about them, the large, wide, bizarre. They come early, and they may not follow the P wave. They don't follow a P wave, they're out of place, right? We said they're not deadly, but they can be dangerous if it's a lot of them, right? If they're multi-configuration, If it's more than 1 in every 10 beats, or if they land right by the T wave, then they can be dangerous. Other than that, they're not life-threatening. But if you see a question, they're going to say PVCs are dangerous when what? So make sure you know when it's more than 1 in 10, if they land close to a T wave, or if they're multifocal, multi-configuration or multifocal. That means they look different every time, right? Every time they either real wide and one is upside, they just configuration. They look different every time they hit. And if it's a lot of them, that's when they're dangerous, okay? Then you have the second one, which is VTAC, ventricular tachycardia. They look like just a bunch of PVCs. That's what they look like, right? They are dangerous, and untreated will cause V-fib, which is deadly, okay? But it's still considered. The reason why they don't say deadly right here, guys, is because when you go a little farther, if some people can have VTAC and have a pulse, right? But it's going to turn into V-fib if you don't treat it. But for a moment, they can still have a pulse and be looking at TV. They may be feeling like, I'm short of breath, something ain't right, right? But they're in VTAC. So, you know, if we give them medicine in time, you can fix it. But for your case, ventricular tachycardia is a deadly arrhythmia. It can lead to death if it's not treated.
So how long does it take to go from VTAC to VFib? Like how much time will we have to recognize it?
It just depends on the patient. Depends on how strong the patient's heart is. It can be quick. It can even take a while. We might even have to do a shock, what's called cardiovert, where we give them a shock, but it's just a little shock. We give them a little sedation and we do a little shock to try to shock the heart back into a normal rhythm. That's what we do when we defib. Defib means defibrillation. That means shock. Now, don't get that mixed up with depolarization. Defibrillation means you shock the patient, okay? And what we do is we try to shock the heart into going back to a normal rhythm, right? Sometimes it works, sometimes it don't. So you're trying to get it to synchronize back to where it's supposed to be. SA, AV, bundle of his, Purkinje fiber, bundle branches, and then Purkinje fibers, right? And kind of shocks that ectopic foci out of the way so it can do what it's supposed to do. All right. That's the reason why we shock. Now we can shock with a whole lot of energy for VFib when they're dead, or if they're having something like a real bad arrhythmia or VTAC with a pulse, we can do a little bit of cardiovert, which is just a small little shock, right? Just a little light shock to try to see if we can shock the heart back into a normal rhythm. Okay. But like I said, you don't have to remember that. Just know that VTAC is one of your deadly arrhythmias. All right. The next one, VFib. VFib is already, if that happens, it's life-ending if we don't fix it. Life-ending. Ventricular fibrillation. Look at number 2. Physiologically the same as what? Physiologically the same as what? Number 2.
Cardiac standstill.
Cardiac standstill. It's on the PowerPoint. Oh, okay. Cardiac standstill or asystole, same thing, because it's just quivering. It's not contracting. CPR must be initiated and you must defib them. So you can remember that. VFib, you must defib. VFib, you got to defib. And defibrillation is electrical shock to totally depolarize the heart and to allow synchronization of repolarization. Trying to shock it back to normal. That's what they're saying. And of course, you must stand clear of the bed or you're going to get shocked too. Number 5, asystole, flatline. No electrical activity and no movement. Just a flat line. And then EMD, which is electrical mechanical dissonance, which is electrical activity, but no pulse. And notice how it says it's also known as what? Pulseless electrical activity, which is PEA. So your 4 deadlies are right here: VTAC, VFib, asystole, and EMD. VTAC, VFib, asystole, EMD. All right, now we're going to stop there because tomorrow, Monday, we will finish up the finish up the lecture with the cardiovascular diseases. Cardiovascular diseases. Okay, we got a lot of diseases that are cardiovascular in nature that we're going to talk about. Okay, there's only this one, really, and that's the last slide is cardiovascular disease. But I want to, some more in the notes, of course, about cardiovascular disease, and then we'll go over some sample test questions and some class work, do some stuff like that to make sure you guys are getting prepared to take this exam on Tuesday and for the lab. So over the weekend, your homework is to do those 2 sets of clinical terms, right? 2 sets. You got page 206 in your Egan's book and page 268 in your Egan's book is your homework. That's the rest of the homework for today, right? It's due on Sunday. Then Monday, we'll have a different assignment, right? And then Tuesday, you don't have a homework because that's your test day, right? So for this weekend, your homework is do both sets of clinical terms or key terms. They're in blue in your Egan's book. They're not due till Sunday at midnight. So you got all weekend to do it. Make sure you guys do your reading, study, go back and look at the lectures again if you need to. But study. You can look over that homework if you want to do more of the homework just for yourself to get it ready because we're almost done, right? You should have covered pretty much everything except for the diseases, and they can be found in the reading. But the main thing is to make sure you do those terms and start working on your laboratory work. In the syllabus, it tells you what questions to do in the lab book and the pages. And this is the lab book, just in case somebody doesn't know. This is the lab book. Okay, this is the lab book. So there are some pages and chapter in the lab book I want you to work on over the weekend. And it's only like a couple, like 5 or 6 questions, but it will help you see what we're expecting. It kind of tells you the process of doing a project. Like if I say we're going to go in and do a blood pressure, it's going to talk about how the patient should be sitting, both feet flat on the ground, and all that kind of stuff. You need to look at those, answer some of those questions, and it also helps you with a lot of information. The lab book has a wealth of information. It even has some normal values and all kind of stuff in the back. See this stuff here? It's got formulas. All these different formulas and stuff. This is stuff you want to learn in respiratory. Maybe not 210, but all of these formulas and equations.
In the margin, do it tell us what page?
In the what?
In the margin, do it tell us what page you want us to do?
Yes, it's in the syllabus.
Okay.
Look at your syllabus for Tuesday's lab, and it'll tell you what lab pages and chapters to have ready for you on Tuesday. So when you come into lab on Tuesday, you need to have those questions ready. Okay. Already answered so that we can go over any questions you got before we take the test and do that. But I was just showing you in the back, it's got a wealth of information in this lab book about all these different formulas that you want to use in respiratory. Right, that was 1 page. This is another couple of pages. It's a lot. This is more than breathing treatments, guys. That's what I'm trying to tell you. Way more than breathing treatments. So the more you take serious now, and the more you really try to get this stuff together, the better you'll be when you get introduced to all this stuff later. When you get to 220 and 230 and 240 and 250 and have to do the modified shunt equation and the alveolar air equation and all this different stuff, it'll already be in your subconscious because you've been looking at it, okay? This book is a wealth of information, and it's in the syllabus of what to do, okay? Have a safe weekend. Like I said, you don't have to turn in that work until Sunday by midnight. If you turn in early, that's fine. I'm putting the attendance in Monday morning. So whoever hadn't turned in by midnight Sunday will be tardy absent for today, okay? That's how that works. But it should help you with knowing these terms, looking up these terms, and make you read at the same time, right? Well, a lot of information was covered today. You guys did well with participation. I appreciate it. and let your friends know. If anybody missed today, it's a lot of information. You missed a lot. Hard to come back to it. Okay. All right. So I will see you guys on Monday. We will start our tutoring next week. Okay. Because I wanted to see how many I really got. And then I will give you some days for my tutoring sessions on Monday, and what days and what times you can log into Zoom and do some tutoring. Okay. Other than that, you have a good weekend. I can't think of anything else. And I will see you guys on Monday. Now, today was open for Alpha students. So Monday is open for Omega students. Okay. Any Omega students that want to come to actual class on Monday, you're welcome to. All right. If you are an Alpha student and you want to come Monday, you can hit me up, because I've only been having 1 or 2 people come to class. So if it was an Omega student that wanted to come today, they could have came, right? So I mean, I was thinking under the impression that all the people were gonna want to show up, but I guess I was wrong. So Monday, Omega students are open to come. If there's any Alpha students that want to come, you shouldn't have a problem, because I doubt if all the Omega want to come. Okay, so just show up. All right, we'll see you Monday. Have a good weekend. Okay.